This lecture focuses on endovascular management of intracranial occlusive disease. Presently, we will look at the different types of intracranial occlusion that can occur and their respective endovascular treatment options. The types of intracranial occlusion we describe here are large vessel occlusions, intracranial atherosclerotic disease, vasospasm, and moya-moya disease. Large vessel occlusions are obstructions in large major intracranial vessels. These vessels include the internal carotid artery, middle cerebral artery, anterior cerebral artery, posterior cerebral artery, basilar artery, and vertebral arteries. They are relatively common, making up 20% of all ischemic strokes, and occur with an incidence of 24 per 100,000 people. The etiology of large vessel occlusions are either embolic or from a ruptured plaque. Embolic large vessel occlusions usually originate from cardiovascular sources such as the heart or the deep veins. Thrombotic large vessel occlusions often come from ruptured plaque from the carotid artery or from the intracranial circulation. According to several large randomized controlled trials, the American Stroke Association has recommended specific guidelines for thrombectomy indications. These include the presence of an intracranial large vessel occlusion, either the ICA or M1 segment. However, the M2 or 3 segment occlusions can also be considered. A good pre-stroke functional baseline, modified Rankin scale of 0 to 1, age greater than 18, the NIH stroke scale greater than 6, presence of any hypodensity on non-contrast CT as measured by the aspects greater than 6, treatment initiated within 6 hours. Certain patients with a penumbra on perfusion imaging can be treated up to 24 hours or more. The guidelines note that while there is less data for anterior cerebral artery, posterior cerebral artery, vertebral artery, or basilar artery occlusions, treatment with thrombectomy can be considered in these patients. In terms of endovascular technique, several devices can be used for thrombectomy. The first type of device is a stent retriever. In this procedure, a microcatheter is advanced beyond the clot, and a stent retriever device is deployed around the clot. After several minutes, the device is recaptured and removed from the intracranial circulation in hopes that the thrombus is entangled within the stent. The other type of device is an aspiration catheter. Using the ADAP technique, a microcatheter is used to navigate to the face of the clot. An intermediate catheter is then navigated to the clot, and aspiration is turned on through the intermediate catheter. After several minutes, the catheter is withdrawn in hopes that the thrombus is within the aspiration device. This figure depicts a patient who presented with left-sided weakness and was found to have a M1 occlusion on the right middle cerebral artery. Thrombectomy was performed using the ADAP technique, direct aspiration using a suction catheter. After one pass with the suction device, full reperfusion was achieved. In panel B, you can see the guide catheter marked with an asterisk and the intermediate catheter marked with a cross. The next topic is intracranial atherosclerotic disease, or ICAD. ICAD is due to atherosclerosis of the intracranial circulation, causing stenosis of the vessels. The risk factors for ICAD are older age, hypertension, and diabetes, and other coronary vascular disease. Given that ICAD is an insidious process, long-term ischemia to the brain may result, and recurrent strokes are common in up to 15% of the patients. The standard of care for patients with ICAD is dual antiplatelet therapy. There have been studies looking at either angioplasty or stenting of these stenotic vessels, and it has been found that both of these procedures have risks that outweigh the benefits. However, in cases of recurrent strokes, stenting or angioplasty or both may be used to prevent further strokes. In this case of a patient who presented with aphasia and right-sided weakness, we found a left M1 occlusion on CTA. The patient was brought for cerebral angiography where the M1 was found to be occluded. After aspiration, there was noted to be an area of stenosis at the distal M1. Given this, a stent was placed at the M1 segment. In panel B, you can see the guide catheter marked with an asterisk and the intracranial stent marked with a cross. The final runs showed good reperfusion with a patent M1. Another type of intracranial occlusive disease is vasospasm. Vasospasm can either be spontaneous, as in cases of reversible cerebrovasoconstrictive syndrome, or post-hemorrhagic, which is more common. Post-hemorrhagic vasospasm often occurs following subarachnoid hemorrhage and is common 3 to 14 days post-bleed. The subarachnoid blood inflames the blood vessels, causing constriction of the cerebral circulation. This can typically cause delayed cerebral ischemia. Given the risk of vasospasm following subarachnoid hemorrhage, patients are typically treated with a calcium channel blocker. If vasospasm does occur, as indicated by a delayed neurological deficit, the patients can be treated with hyperdynamic therapy, including augmentation of the blood pressure. In refractory cases, endovascular management can be used. Typically, patients are treated with intra-arterial verapamil, which can improve significantly the vasospasm. However, in severe cases, balloon angioplasty can be used to open blood vessels. In this case, a patient presented with subarachnoid hemorrhage due to a ruptured anterior communicating artery aneurysm. The patient underwent clipping of this aneurysm. Several days later, the patient was noted to decline neurologically, and vasospasm was detected on CT angiogram. The patient was brought for cerebral angiography, where intra-arterial verapamil was injected. However, given the severe nature of the vasospasm, specifically in the M1 segment, a balloon was used to angioplasty the M1. In frame B, there is a balloon inflated in the M1 segment, as noted by the asterisk. Following balloon angioplasty, there is noted to be significant improvement in the vasospasm. The last type of intracranial occlusion, as described in this chapter, is moyamoya disease. Moyamoya disease is a progressive, spontaneous occlusion of intracranial vessels, most commonly affecting the M1 segment, or the distal internal carotid artery. While patients can compensate well for this spontaneous occlusion due to collateral circulation, it can cause focal neurological deficits. Endovascular options for treating moyamoya disease are limited. Since moyamoya disease is a progressive process, there is often no means to access the area of occlusion. The typical treatment is either indirect or direct bypass via a surgical approach. In this patient with moyamoya disease, we note the chronic occlusion of the left M1 segment on AP and lateral angiogram. There is a classic puff of smoke appearance of collateral blood circulation around the occluded M1 segment. In frame C, we note the collateralization of the posterior cerebral artery to the middle cerebral artery territory. In conclusion, we have described multiple etiologies of intracranial occlusion, including large vessel occlusion, intracranial atherosclerosis, vasospasm, and moyamoya disease. Endovascular reperfusion is definitely possible and often pursued in acute cases. Endovascular options include thrombectomy, either with a stent retriever or aspiration catheter, stenting, or injection of intra-arterial pharmacology, including TPA, heparin, or verapamil.